young people with an asymptomatic case of COVID, mild or just didn't even know they had it, have brain changes, like gray matter changes in their brain, right? And
Crazy.
IQ testing, and you're losing IQ points like every time you're exposed. So
Yeah.
if we know it's doing that in the brain, what's it doing in the other organ systems? And so it is a true age accelerant. And it will behoove all of us not to be dealing with this in all of our patients on a daily basis. And I know it sounds like I sound like the sky is falling and it's hard to buy into, but it is true. I mean, I have patients walking in my door every day, and I do because I'm a precision healthcare doctor, I'm going to be proactive, right? So now I have a bunch of these biomarkers on everyone's panel.
Right. No matter what they're coming in for. Right. Yeah. Welcome back to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. My name is Dr. Scott Scher. It is a pleasure to be back with all of you. Today's podcast was a tour de force on COVID, long COVID, acute COVID, strategies that are being developed now by Dr. Robin Rose and her team. This is all in the realm of Dr. Robin Rose's practice, and Dr. Robin Rose is my guest today, a fantastic human. Here is a little bit of a bio of Robin. So she is a board certified gastroenterologist and internal medicine physician. She trained in gastroenterology and hepatology at Beth Israel Center in New York City. And she is also a functional medicine provider with the Institute of Functional Medicine. She left conventional practice in 2020, actually right around and during the pandemic, as she became basically obsessed with the COVID infection, long COVID as it now is, but acute COVID infection, chronic COVID infection, and everything in between. So this podcast is a special episode, I would say, because we really did take a big dive into COVID itself. We talked about spike protein. We spoke about how it can act like a phage in the gut and then infect the system with all these toxic peptides that it develops. We talked about acute infection, acute treatment. We talked about long COVID, vaccine-induced COVID versus long COVID from the actual virus itself, various strategies that Robin is using in clinical practice, how it's so important to think of the spike protein as being a senescent cell virus. Basically, what it's doing to all of us now is being an age accelerant, and we're all getting infected with this all the time now, and all these various strategies that Robin's using in her clinical practice, both acutely, chronically, not only directly infecting the spike protein and the virus, but also rebuilding the gut. We talked about various peptides, various repurposed drugs. We talked about rebuilding the whole system and what she's seeing in clinical practice with neurodegenerative disease that is happening early, cancer, autoimmune problems, chronic issues otherwise, like so many different things that are happening. So what Robin is really, really good at is taking research and then bringing it into her own clinical practice. She's based in Connecticut. She has a telemedicine aspect of her practice. She speaks about COVID infections, her framework, her protocols. There is so much to dig into with Robin here. And it was just really kind of scratching the surface. But this was so fun to record. I really hope you enjoyed. If you have had COVID, if anybody in your family has had COVID, really anybody at this point, this is a podcast that really is a must listen. The frameworks that we think about are so much different now than we thought about earlier. And the aspects of this that, that we thought were happening early in the pandemic are not even an issue now. And what we thought was an issue before is a huge issue now. So if you're listening to any podcast that we've done really on infectious issues, specifically COVID, like this is the podcast to listen to. She is just a wealth of information. So I really hope you enjoy this episode with Dr. Robin Rose. Enjoy. Robin, it's good to see you.
Good to see you, Scott. Thanks for having me.
I am super excited to have you. It's been a long time coming from the first time we met at the Integrative Health Symposium in New York City, pre-COVID or during COVID or after COVID?
God.
I don't even remember.
It was during COVID. It was
during COVID. Yeah. It was definitely an interesting time, especially in in that city. I know it's not your fair city, but it's close to you. So
well, I grew up there. Up there.
That's right. Mm-hmm. And I know your practice has evolved a lot. There's been lots of evolutions of your practice. I know you started off very conventionally and have moved over, to the dark side, as we say, or to more of an integrative perspective. Yeah. But today I really wanted to bring you in because we have a group of docs that we're a part of called the Longevity Docs, and a
Love.
shout out to Longevity Docs and Dr. David Liu and everybody. You guys are great.
Love them all.
It's just a fantastic sort of ecosystem and think tank, and where you always shine is on the work that you're doing in both acute COVID care and long COVID. Because I know you've done so much work here. So how did this evolve in your practice to start off with? And then we can kind of go into like the framework and the things that you're doing in detail.
All right. So I don't know if it's that much of a funny story, but literally right before COVID hit, in the very beginning of March of 2020, I went to go visit another functional integrative practice in Kentucky. Okay. I went with my business partner at the time. And this was when I was really trying to figure out the leap I was going to take from my conventional medical practice to my functional medical practice, and sort of like, take that leap of faith and leave. And I was just trying to put the pieces of the puzzle together. So part of me did not want to get on the plane. I was like, I had been following the COVID. So I was pretty obsessed with COVID. I had been following it since January of 2020. And I knew it was coming. And my husband also had a lot of business. He does a lot of business in China. And we were just getting like a lot of crazy pictures and texts and all this information coming out of those people from China about like what was going on. And it was like super scary. And so I remember I got to the airport, I went and it was like March 3rd, right? And like everything like sort of started shutting down like around the 9th here, I think, or something. And I literally get to LaGuardia Airport. I did not touch anything. I didn't sit down. I wouldn't use the bathroom. I had like my scarf like wrapped around, my whole face. And I remember like just like on the plane, I didn't go anywhere. I just stayed where I was. It was just ridiculous. And then I got to Lexington, Kentucky, and I was like, okay, I felt like sort of safe there. I'm like, I don't think there's any COVID here. Like I felt pretty. And then like the next day, 2 days later, we get back on the plane. And I remember there was this guy like coughing his brains out. And I was like completely freaked out. I had the thing like really, tightly wrapped around me. And literally like 2 days later, I'm in my endoscopy suite, like doing colonoscopies. And I start sneezing like crazy. And I come down with these insane URI symptoms, like hit me so fast. And I don't get sick easily. Sure. And if I get sick, I like usually beat it fast and it doesn't linger. And this thing was insane. I didn't have like the pulmonary symptoms. It was all upper, but it was like bad. And I was freaked out. So they wouldn't let me go back to work, the hospital. Cause at the time I was employed by the hospital, the Stanford Hospital.
Sure.
And they were like, no, you might have COVID. You can't come back. So at this point now I'm convinced I have COVID. So now I'm literally reading every single research publication I can out of China about COVID. I'm discovering that all these people have a broken gut microbiome, all these, whatever, like I'm reading and I'm attending every international webinar all over the world of like, that are taught by these like major virologists, to learn everything I can about this virus, like the receptor binding domain, the furin cleavage site, like the S1, S2 subunit, like anything you could think of, I was like learning. And then Scott, I wrote a primer. I sat in my dining room for 18 hours a day. I'd be up till like 2 or 3 in the morning. I didn't eat. I must have lost 20 pounds in like 2 or 3 months. I went through hundreds of articles and I wrote this primer using all natural polyphenolic compounds or, vitamin D, quercetin. I wrote like blogs back then. I mean, I'm not really anybody and no one knew me, but I was writing these things that then got published like months later in like the New York Times about what it could do for COVID. Right. And I just like was like, okay, I figured all this stuff out because it was really important for me. My why was I want to be able to help all my loved ones and protect them from this. Because I live outside of New York City and I saw like what was happening and I was like beyond freaked. And plus I thought I had it and I was going to die. Seriously, I'm being really serious. Yeah, like I was psychotic. Psychotic.
I mean, so 18 hours a day for weeks, you were just pouring through.
Weeks. And I wrote this primer. I still have the primer,
Amazing. Yeah.
I mean, I never like really built on it, but for at the time putting in what I did, it was pretty good, Yeah. And then I got everyone I knew like on all of these natural, compounds and melatonin and all these things that we know now like can help. But like I was using them in March of 2020 and giving them to whomever I could. Quercetin, I was using all of that then. Yeah.
It's amazing because it was such a hard time, for the first 6 months or a year at least, to talk about anything that wasn't straight up, medical treatment, right? You couldn't talk about vitamin C online without getting banned. I mean, how did you end up getting this
nobody
information?
knew me. So no one really knew me. So it was just like on my Train Health website, really. And who knew me? I wasn't getting in trouble, right? And I wasn't making claims. I was just showing the evidence and providing all the evidence and all the research, because all the citations were there of what it does and how it can help as a very potent antiviral, especially in coronaviruses, right? And that's what I was really showing. So then, really, just to speed up, because we don't want to talk about this all the time, but then I gave notice at my conventional practice with the hospital in June. Yeah. And then I left for good in September and opened Train Health. And
amazing.
And then I was doing all the functional stuff that you do. And I was checking all the advanced biomarkers, quadruple of what you would get from your regular, practitioner when you go for a physical exam.
Mm-hmm.
And before this, because before I even left, I was doing so much work in the gut microbiome space. And, Karen Cushnan, we were just talking about from Microbiome Labs, and all these wonderful, amazing people came into my life and were just amazing mentors and really guided me and taught me so much. And so everyone in my practice too at the time was getting next generation sequencing of the gut microbiome. Right. Mm-hmm. So I was doing that and all this blood work. And then I noticed that in probably the beginning of 2021 is when I really started noticing. I was noticing there was a lot of abnormal patterns on the blood work that I never saw. And as a gastroenterologist in my conventional practice, I was seeing thousands and thousands of patients a year. And I always did CBC, I did iron studies. And I just was seeing bizarre, I noticed everyone was leukopenic. Nobody had a white count anymore.
This is people that weren't just infected. You're just talking about in general.
No, this is my regular patient.
Yeah.
And I was what is going on, And then I just noticed, the gut microbiome sequencing, and I actually met with Karen about this, because I was why does nobody have bifidobacteria anymore? Or why, I just noticed these patterns, because I'm a big pattern recognition person. And I just thought it was very oddly bizarre. Right.
This is prior to all the vaccinations coming in. You were just noticing.
This was right around that time. So then I couldn't, it was a little conflated, so I wasn't, I don't know why, I didn't, because I think what happened was my practice really started building a lot more into 2021, because I had just started. So I was getting a lot more blood work back then, and was doing a lot more of the sequencing. And then I started to notice more of the patterns that I could compare to what I was doing in in the second half of 2020 versus 2021.
And some of those patterns, you said leukopenia. What else were you noticing?
Leukopenia. I noticed, and as a gastroenterologist, this was very bizarre. And I did do further research on it. And Bob Miller, who's a naturopath, and he does a lot of he's brilliant. He helped me a little bit. I noticed that everybody, because I always did iron studies on people. And I noticed that a lot of people had normal or high iron levels, but very low ferritin. And I thought it was very bizarre. And he showed me that it had something to do with the HEMOX pathway, the HMOX, HEMA? Yeah, am I saying it right? HMOX1.
Yeah.
And that he showed me because, he has this crazy, all of his pathways, he's really brilliant. And he was showing me how when you want to convert iron into its storage form, ferritin, it uses that enzyme, but that enzyme was being really eaten up in all these other inflammatory pathways that had to do with COVID.
Got it.
So it was okay, that's not a necessary mechanism for life necessarily, right? So
right, diversion.
Probably why everyone's stuck. And I thought that was weird, because I was that's weird, because as a gastroenterologist, I'm usually the iron deficiency goes with the low ferritin, and that wasn't happening, right? So I don't know, just weird things. And then I started gravitating to all these other functional doctors that I got introduced to that were looking at the same things. And then we started checking D dimers, and then we started checking TGF beta 1. And then we started checking, it was we just kept building a list of things that each one of us noticed maybe before the pandemic was never really an issue, or was an issue in a certain subpopulation. But then it was we were seeing it in 70% of our patients, 80% of our patients, the amount of people walking in with elevated D dimers, with TGF beta 1 in the 8,000s, 10,000, 15,000. It was insane. you know?
Right.
And then it was like, okay, then we like had to start backing into all the pathways, like what is causing this, right? And then I worked with Patterson's group for a while. And then I worked, my dear friend, Suzanne Gossa, who's a brilliant functional neurologist, mentored me so much because there was so much neuro COVID. And, you had to become like an immunologist, a neurologist, a cardio,
everything,
a specialist, because every single organ system was involved. Right. And then I finally met this big research consortium. It was like more of a global research consortium in Europe. His name's Joachim Gerlach, and he's a scientist, more of like an engineer. And he understood this disease like I have never met anyone, like nobody, even all these virologists I know, like he actually had been working on it since 2019 or the beginning of 2020. And he was able to show like the 250 or 300 different pathways that are affected by SARS-CoV-2 or the spike protein, right? And he was able to like back into all the pathways, like, looking at it from an upstream standpoint, right? And using all these specific polyphenolic compounds and all these things that could work really synergistically together to impact change on all the pathways collectively, right? Because targeted drug therapy was just sort of not an option, right? Because if you really understood the disease, you knew it wasn't just only this receptor. And oh my God, the ACE2 receptor, no. There were, at that point when I met him, he had already found, based on all the research and the armamentarium of like, papers that he had collected, like tens of thousands at that point from research that was being done all over the globe by major academic institutions. I mean, you're talking about 24 host cell receptors that the spike combined to, right? Wow. And so I still find it funny that everyone is so like, honed in on this ACE2 receptor because, oh my God, it's like a millionth of the issue or the problem of like what we're really dealing with.
Pardon the interruption. This episode is brought to you by Health Optimization in Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our foundational module, Metabolomics. The optimizing of metabolomics is so important for foundational health, including in COVID infection, whether it's acute COVID, long COVID, recovering from either. Check it out at homehope.org and save 10% on this module or any module by using code podcast10 at checkout. Now back to the show. Wow. So 24 receptors at least that are affected by the spike protein. So that's where I wanted to go first. It's like, and this is one thing that, we were talking about a little bit before, like the spike protein, right? This is kind of the fulcrum of everything, right? And I wanted to ask you, let's kind of dive into that because I think that's what you're just describing. This affecting all these different pathways. Like most of us don't really understand what this is. Okay. We have an idea, even in the clinical realm, like let's talk about spike protein, what it is, where it lives and like, and let's start there. And then maybe we can talk about how you get it the hell out. But I think that the first start is like, and that's kind of you've been driving at, but like, let's talk a little bit about that.
So one thing about the virus, and I think we could talk about this a little bit more openly now because Congress just came out with their 500-page report showing
I saw this.
Man-made. Most of us figured it probably was because being that lab was sitting in the middle of the wet market in Wuhan and it was that grade of a laboratory, you probably could figure it likely didn't probably come from a bat, but whatever, right?
Yeah, I saw the report too.
And the fact that it's such a beast of a disease, right? And we're really, obviously every day we're knocking in another door of like what this does, right? But this is not from nature. This is man, right? And even from the studies that were published, some unfortunately still in preprint because I think of the censorship and the issues around it. But back in 2020, January 2020, then another one, May 2020, showing that there was, 4 amino acid sequences or motifs that were, highly resemble or are very, very HIV-1-like, right? Mm-hmm. Inserted in the virus. And then, the fact that the furin cleavage site, it has 10 to 20 times more affinity to the receptor binding domain than any coronavirus before, right? So these things were enhanced and made, that's where the gain of function obviously then, right? It makes sense. So this was not natural by any stretch of the imagination, right? And so this spike protein is so virulent, right? And it's so potent and powerful in what it can do. and we know that the spike protein from the virus, and unfortunately now we understand from the vaccine as well, that it has such a high affinity for all of these different host cell receptors, right? And that's why it can impact all these different organ systems, right? We have this global impact on all these different biological systems in our body. Some people can have multiple systems like all at once that are being influenced and attacked, unfortunately. And spike protein does not want to be in the blood. It has no desire to be there. And actually, after some certain amount of time, a finite period of time, it will just like leave the body and degrade. It's a magnet for any receptor it comes into contact with. And it wants to attach to that receptor and then get inside the cell where it does its damage, right? And once it's inside the cell, it turns the cell senescent, right? And we all know our longevity, right? We talk about cellular senescence all the time, right?
Not good.
And so, right, which is horrible, right? And so once you have these senescent cells, like you have these these zombie cells, half dead cells, like throwing off all these inflammatory cytokines. And what we even know more now is what's so dangerous about this is especially given whatever your spike protein load is and stuff, like once that's in those senescent cells, we know those senescent cells with spike can then also impact healthy cells that are very nearby, right? So it's this horrible domino effect.
So you talked about spike protein load, and we'll talk about testing in more detail later, because I know you do a battery of things, but is there a way not just subjectively to understand somebody's spike protein load at this point?
So two things. So unfortunately, indirectly, right, we will measure the antibody, right, the spike IgG antibody or the nucleocapsid, right? So we all know that spike IgG antibody can come from the wild type virus or the vaccine, where the nucleocapsid is only coming from exposure to the wild type virus, right? Now that's just a shitty, excuse my language, way of testing, right? Because it's so direct. And then given how often you're getting exposed to the virus or how often you're getting vaccinated, that's going to fluctuate. But we know in a normal immune response, right? We know those antibodies are supposed to wane to nothing.
Yeah,
that's why people have to get revaccinated, they're saying it really is done by 4 months, even not before that, right? The antibodies. So we know that wanes, right? So the problem I have is these people, especially with long COVID, their spike antibodies are through the roof, super elevated in the tens of thousands, right? But again, so not a great way to follow, only because too, I'll tell you anecdotally, and we're going to publish this, really when you follow the patients and all their other biomarkers are coming down and we're treating them, and I think we're mobilizing spike, binding it, getting out of the body, those antibodies don't budge in a lot of people. And I think it's because the immune system keeps seeing it. So it's going to keep making antibodies as you're even healing the patient, right?
So you're not even seeing a change. Yeah.
Some people it comes down, and then some people were saying, oh, let's use it as a marker. But I think it's crappy. What I think is a better biomarker is the microclots. The microclots are super fascinating. We can get into this more, but I think it's a good biomarker because the whole idea, the microclots are stemming from the spike protein, right? Causing endotheliitis, platelet activation, this protein misfolding in the blood. This was all protocolized by Professor Pretorius in South Africa prior to the pandemic. So this we knew existed in patients with very significant disease states like end stage heart failure or refractory heart failure, patients with multiple MIs, end stage diabetes patients, totally not normal. So on a scale of 1 to 4, it's normal to have some a little bit of protein misfolding in the blood and have a little this beta amyloid show up in 1 to 2 out of 4. But once you start getting to 2.5, 3, 3.5, 4 out of 4, that's pathologic. That's not normal.
And that's beta amyloid, or what was the marker there?
Yes.
Okay. Mm-hmm. So what are the other markers you're looking at for microclotting? Yeah.
No, well, this is it. I'm going to show you.
Okay.
See that?
Yeah.
So see these big green blobs?
Yeah.
And and here's some more, and they show up in their different sizes. Look at this. I had one patient that literally looked like a turtle the other day.
Wow.
And this person's was 3.5 out of 4, right? And after we put them through treatment, they came down to a 1.5 out of 4. Look at this. Look at how different
and what is this? How is this being measured? Is this looks like dark field microscopy, or what is this?
Yeah, it's fluoroscopy. Right.
It's fluoroscopy.
So only 3 doctors in the country, or as far as I know, were trained by Pretorius. She came over to train them, and it's Petrino at Mount Sinai. There's another physician at Yale, I believe, and then Jordan Vaughn down in Alabama. So the problem is that the two academic institutions, you have to wait months, if not years. There's a list of thousands of people, IRB, blah, blah, blah. Jordan does it for like everyone, so I send them. And so one of my markers is for seeing if I could remove spike is this, because if I can get the back down to non-pathologic range, that to me is like, okay, I'm getting rid of spike, right? And I can say so far in our samples, 70% of my patients I bring back down to within normal range. And that's amazing. Without triple anticoagulation. All of these doctors are doing triple anticoagulant therapy, which I am not a fan of for several reasons. Obviously, there's so many issues and complications with that, right? But that's just also band-aiding it, right?
Right.
Just because you're breaking the clot down over and over again doesn't mean that you're getting rid of the spike, right?
Right. So that's what I was going to say. So the reason why we use the triple anticoagulation is the idea of breaking down the clot, but you're saying that it's not really doing anything to the underlying reason as to why they're clotting in the first place, right?
Right. And then which is the spike protein
itself.
Right. Yeah. And then these beta amyloid type clots, right? These rubbery microclots, they're resistant to fibrinolysis, right? So they can't be broken down. So so then they started using all these heavy duty triple anticoagulants, which they do move the needle, but then you're committing the person to like how many months, years, or lifelong treatment of this, and you haven't gotten rid of the root cause. And as longevity doctors and functional doctors, we're all about root cause, right?
For sure.
So we got to get rid of the root cause.
Yeah.
Right?
So this makes so much sense. So when you're thinking about the microclotting markers, the beta amyloid is one of them. Are there any other markers that you're following, or is that the major one that you're looking at?
No, I'm not even so it's funny. We'll get into some of the markers. It's beta amyloid. It is protein misfolding that's producing the beta amyloid, right?
Okay, sure.
So it's this diagnostic test that I'm using as a biomarker. Does that make sense?
Sure.
However, and we'll go into this in more detail, but I do follow the A beta 42/40 ratio, right? Which we know has been used to measure like cognitive decline, precursor to Alzheimer's disease. And many studies show it is a good marker. There's a bunch of studies that have been recently published. It correlates very well with, beta amyloid on PET scanning. It's, it's even more highly sensitive and specific when you pair it with the ApoE gene, things like that. But what's so fascinating is that beta amyloid, right? Like when we were thinking it's like you have to like think about it differently, because you're like prior to the pandemic, it's like, okay, this is happening because of Alzheimer's disease or because this person is going on to it. But now it's like, oh, are we picking it up more in the blood because of these microclots, right?
Got it. Okay.
But remember, it's like hard. I even forget myself because like you start to think so like one dimensional and instead of like three dimensional, three dimensional. But remember, these microclots are in all the vessels all over your body, right? And so you're talking about the neurovascular system, the cardiovascular system, the vascular system of your kidneys, your lungs, your gastrointestinal tract. This, it's everywhere. So you almost get stuck and you're thinking, oh, it's like in the blood, but it's like infecting all of these different systems in our body. And then, depending how big the microclots are, they're jamming up different parts of your circulation, right? Because you have, remember, you're like capillaries, and then your small venules, veins, bigger, right? And then your arteries, arterioles, capillaries. So in the smaller sense, I think it's up to 5 microns or something. I have to go back and look at the measurement, but that starts jamming up your capillaries, right? And so if you're jamming up your capillaries and those capillary beds can't perfuse or get blood to your cells, tissues, and organs, God, imagine why all these people feel like they're suffocating and they're underwater and they have horrible chronic fatigue and brain fog and post-exertional malaise, right? Like think of like all just that alone. Right. And we're not even talking about the 200 plus other things that are going on.
With all the other receptors that it can potentially be affecting, not just in the blood, the vascular system itself, right? Because you're talking about like in the brain tissue. I know you've even looked at, like you were talking, I know in our group about MRI scans of people and you're looking at some of this microclotting, but you're also seeing other damage as well, right?
Yeah. So like we do, so for a long time, and it's hard to get them approved. So I wasn't doing them as much because it's so funny. Like it's so great to have data and like we love that in our longevity group, but God, these people are so sick and just like want to get better. And
Totally.
it's so hard to like be like, okay, well, let's do this like prospective study and let's like, put this person in the control group and this, like it's awful. Like you just want,
I understand.
I mean, these people like, this is awful. This is like, they're so debilitating. You're talking about on the same scale, if not worse, of cardiovascular disease for all our cardiovascular friends. I mean, literally.
Yeah.
And then you can get into what is someone's long COVID? Like they say, like, okay, 42 million people have had it. 27 million people did have it recently. And now 17 million are currently living with it. But where are those stats really coming from? And what is someone's long COVID? Like, listen, I don't mean to like rain on everyone's parade, but as longevity doctors, like, I'm sorry, but this is something we have to significantly think about because we are being exposed to this virus over and over again. It mutates at like an exponential rate, right? Mm-hmm. And not that it's more pathogenic, but it's more infectious and contagious. And now people are getting infected 2 or 3 times a year. And we know from published papers, especially ones that are done in the neuro realm, that young people with an asymptomatic case of COVID, mild or just didn't even know they had it, have brain changes, like gray matter changes in their brain, right? And IQ testing, and you're losing IQ points like every time you're exposed, It's crazy. Yeah. So if we know it's doing that in the brain, what's it doing in the other organ systems? And so it is a true age accelerant. And it will behoove all of us not to be dealing with this in all of our patients on a daily basis. And I know it sounds like I sound like the sky is falling and it's hard to buy into, but it is true. I mean, I have patients, Scott, walking in my door every day, and I do because I'm a precision healthcare doctor, I'm going to be proactive, right? So now I have a bunch of these biomarkers on everyone's panel,
right? No matter what they're coming in for, right? Yeah.
Oh, and they look like a disaster.
Yeah.
Right. And then it's like, but then it's like, oh, what do you do? But like, you want to like avert the crisis, right? You want to change what we're constantly being exposed to. So, that's a whole other discussion about prophylaxis and treatments, but
well, I think there's so much to talk about here, but I think what I'd like to kind of talk about, at least initially, is like, I totally understand like the burden of disease is huge now. And I think that your perspective obviously is you've been in this world, you're seeing it on a day-to-day basis, and you're looking at it through the lens of acute or chronic COVID because you see everybody getting exposed acutely, chronically, et cetera. Like when you're thinking about like from a workup and treatment perspective for somebody with an acute COVID infection now, I know you did all those papers like, all those years ago, like it had all these supplements and like now we have so much more information and I know you do. Let's talk a little bit about what your acute workup looks like for somebody that comes in for like, let's talk about acute COVID first, like acute COVID infection, right? I know things have changed a lot. Like you said, people aren't, in the hospital on ventilators anymore. Thank God. That's great. But that doesn't mean that they don't get all these, what you're trying to prevent acute now is all the long-term sequelae that you just described. So let's talk, I think that might be an easier place to kind of dive in. And then we'll talk about
I know
bigger
it's all so
realms
I know. I'm sorry. I'm all over.
No, this is great. No, I love it. So, I think it's so important. Yeah.
So here's the deal. So, all right. So let's talk about this for a second, because this is going to lead into why we changed our protocols into acute COVID. So Carlo Brogna and Simone Cristoni and a bunch of physician scientists in Italy, they have numerous publications in the long COVID realm. Okay. And Carlo et al., Brogna et al., they are the ones that discovered that this virus is an enteric virus. Okay. It behaves similarly to the polio virus, which they also discovered. They are both phages. They are both bacteriophages. Okay. So the virus invades the bacteria of our gut microbiome. Okay. Once that happens, the gut microbiome is like completely taken out, because then it takes over that bacteria and the virus replicates. So they have electron microscopy pictures showing you like the bacteria teeming with SARS-CoV-2, right? And then SARS-CoV-2 then starts basically throwing off all of these different toxic-like peptides, they call them, okay? And they have identified, Scott, over 2,000 different toxic-like peptides. And in the average person, that you can have anywhere from 3 to 12 of these circulating, okay? And there's all different ones. There's like conotoxins, which are neurotoxic. After they come out of the gut, they see the blood, they get it across the blood-brain barrier. There's natriuretic peptides. There's alpha neurotoxins. There's SPPLA2. There's metalloproteinases. I could, whatever, I'm not going to bore you. Like, there's all these different peptides, and they all interact with our different biological systems and destroy enzymes and do all this bad stuff, like, to our body. And so it's funny because it's like, okay, it's hard to wrap your head around, like, God, this is happening too, right? Because it's like, where is it really starting?
Right. Yeah.
You know what I'm saying? It's like, but it probably is in a lot of ways starting in the gut. And then seeding the rest of the body, from the gut, if you think about it,
Sure. Yeah.
And they know that not just the virus, but the spike protein as well. Like, if you find the spike protein inside the gut epithelium, it's also throwing off the toxic-like peptides as well. So now you're dealing with two things. Now you're dealing with spike and you're dealing with persistent virus. It's like it can act independently from the virus.
Right.
That's why it does what it does with patients that have issues post-vaccine, with these post-vaccine conditions, right? Because it can do this.
The vaccine induced is not the virus, it's just the spike, right? Or is it both as well?
Spike. Right. It's just the spike. But the spike so here's the deal. But then depending on if the mRNA is inside the cell as well, that cell can then become a spike producing factory. Right.
Which is not supposed to do. Like, it wasn't supposed to do that, right?
No, but it does. And we know it's proven. Yeah. Or you just have these spike proteins, right, inside the cell, which sucks also, because then you have your cellular senescence and you have immunosenescence and this type of like every senescence under the sun. And then you know what that's doing. And then the other crazy thing it does, and this has been studied within minutes of like being exposed to SARS-CoV-2, once that gets inside the cell and the senescence starts, like, you get these syncytium, you get like a conglomerate of the senescent cells sort of like coming together, and these big syncytium form. And then inside those syncytium lives like persistent virus, toxins, like, all this garbage, spike protein. And then, like, how do you mobilize it and get it out of there? Right.
Yeah. Yeah.
So these are all the strategies we'll talk about, but this is what's happening inside of us, inside the interstitial spaces, and like in all the tissues. Like, think about it. Like, and some people it could be worse in, and some people not,
And there's a lot of factors that go into that, of course, at least I think we know about, patients that have a much more challenging road versus those that don't. Although I thought an interesting one, kind of as a side note, like, they thought that smokers were going to do really bad, right? This goes back to your ACE2 thing, right? But the actually smokers did much better than they anticipated. I think they thought this is probably because of the ACE2 receptor, although that's just one of.
But they got it wrong, because it's like one of like 25. Yeah. And like, and I really shouldn't say this, but like, well, I won't say what it is yet, but the ongoing research we're doing, we identified a 26 receptor.
That's exciting. That's very exciting.
I know.
Although terrible, but I know, but
terrible, terrible. But I mean, I shouldn't be smiling. I mean, it's just insane, it's actually insane that there's like, because there's just so many more receptors that we probably, don't even know about. Right. And it's like DPP4 and ADAM17 and NRP1 and whatever. I can name 1,000 different receptors, but it's like there's so many of them. And it's just devastating.
Yeah. So when it comes to, like, this is devastating, obviously, right? You have the virus itself, you have the spike protein coming from the gut, seeding the rest of the body.
So that's why we'll go back. Right.
So I wanted to focus on, if somebody's coming in with an acute presentation, it's going to be much different trying to prevent a lot of this stuff happening, as opposed to the other aspect, which is like, if it's already there, like mobilizing and binding and moving, which I want to talk about as well, because I know that's like what you do on the chronic side. But if somebody's coming with an acute,
right. So okay. Yeah. So let's talk about it. So now we know it's enteric, it's a phage.
Right.
So the studies that Bronya put out, and listen, we're trying to look at other strategies too, to sort of like get rid of that epithelial lining that's like basically riddled with spike or the virus, right? And then invading the gut bacteria and so on and so forth. Maybe it with more natural compounds, right? Because obviously, as a gut microbiome specialist, I cringe having to give antibiotics, right?
Sure.
But on the flip side, if all of those bacteria are taken out anyway, and they're throwing off these toxic, what you got to get rid of them no matter what, right? So that's how I look at it. And then you just have to rebuild the gut microbiome. So we are giving, so Bronya did studies with amoxicillin with Xifaxan, with or without Xifaxan, or if you're pen allergic, zithromycin with Xifaxan, and basically showed that you can clear the phages with a week's worth of the antibiotics, right?
So this is not treating this is really important, right? Because most people think, no, this is a viral infection. We're not going to treat them with antibiotics. But no, this is for a different reason. This is actually like going nuclear on your gut is really what you're telling me.
Correct.
Okay.
That's such a good term. I love that. Yes.
Yeah.
Yeah.
Yeah, you go nuclear because you're trying to kill off these bacteria, your microbiota that have been infected by phage, basically.
Okay. So why not start there, right? Because we're assuming it's likely concentrating a lot in the gut. Yes, the virus is going to access our bodies through the nasopharyngeal mucosa. Sure, I guess some of it's going to get into our bloodstream that way too and start doing stuff, but most of it's, I think, really, going to the gut in the beginning, maybe. So let's get rid of the phages. Let's get rid of, the virus being harbored in these bacteria. And he noticed that when he did a prospective study, or was it retrospective? I forget now. But
it's all good.
Basically, he took a few hundred patients, and it didn't even matter vaccine status, because you know how there was trying to show if you weren't vaccinated, but it's BS. So he showed whether you were vaccinated or not vaccinated, they had the same results. And the patients that got the antibiotics up front, they did much better. They had a much more statistically significant lower rate of going on to long COVID and having post-COVID complications and all that great jazz, So he has proof of concept, right? And he did so many other studies with this. But so I do, obviously, as a integrative functional doctor, I do a little bit more than just that. So I am thinking also about this spike seeding, like how we just talked about. So the guys, and I'll disclose, the guys that I work with in Europe, they developed this product called Medicinal 9, which I love because, for years I was using all these different polyphenols. So the patients were shoving down 10 different, products, and they have put it all into this emulsified solution that has very good bioavailability, and using the 9 best polyphenol compounds that they backed into all these pathways with, working synergistically, to do all these things, to block the receptor binding domain, the furin cleavage site, replication, all these different things, right? And four of the compounds are natural senolytics, and 8 of them are natural binders to spike protein. So just
what was the name again? I missed the name.
It's called, it was studied, and all the studies were carried out in the development in India. So it's called Medicinals.
Medicinal.
Yeah, Medicinals. Okay. Medicinals 9. So anyway, basically, that to me is a good foundational product because it's going to help no matter what. So I always throw that on board with the antibiotic, but then I start giving other things like binders, other senolytics, right? And all of this we're learning every day. So I don't go too heavy on the senolytics anymore up front because I don't want to be doing too much damage also, because too much of that could not be good either. So it's a little bit of a nuanced, treatment plan and conversation around that. But I'm using that. And then I also am using other compounds. I use a plant-based, actually, omega-3, 6. And we found that the omega-3 is also a good binder to spike. Okay. And then I do still use Ivermectin. I really like Ivermectin. Ivermectin's great. We know that it really helps lower the viral load and inhibits viral replication.
You use horse dewormer, Robin? How dare you?
I mean,
no, it's great, right? I mean,
I find it so benign. I find it so benign. And as a gastroenterologist, obviously, for all those years prior to moving into the space, I used Ivermectins forever, right? And or not, for all these different antiparasitic infections and so on and so forth. I never had any issues with it. I always knew it was such a safe drug, And then once I moved into this space, and I always, I knew it did wonders for, at certain doses for inflammatory bowel disease and cancers, because how the cancers mimic like parasitic, life cycle, like all that stuff, which I totally appreciate. And then when you did all the research on ivermectin in the context of COVID, you saw like this Nobel Prize winning, drug in 2000, I think it was 17 or 14, whatever, 14 or 17. And like how it has all these marvelous properties, right? Like it's an immune modulator, it's an antiviral, like it does all these wonderful things. So why not? Like, what's it going to do? Like, it's not going to really hurt you, So I put it on board, and I find that with the subsequent mutations in the virus, I dose a little higher. Like I'll do 0.4 to 0.6 mg per kg instead of the 0.2 mg per kg. And I do use the ivermectin prophylactically because there were so many studies put out. And there was this one big Brazilian study with 88,000 patients that showed such significant improvements, significant differences in the patients that use it, even that use it sporadically, for, you know what I mean? At like the 0.2 mg per kg dose, or even some, I think they were taking 12 milligrams, whatever, and they weren't even using it even 4 times a month. But the study was based on really using it twice weekly, every other week.
Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, physician-formulated, and pharmaceutical-grade formulas in the form of a buccal troche. For this episode, check out our Just Blue and our Tro Plus Blue if you're a practitioner. These are pure methylene blue products. Methylene blue improves mitochondrial function. It improves antioxidant capacity. At higher doses, it's anti-infective, it is anti-inflammatory, and it's very much involved in these chronic inflammatory disorders that we're talking about during this podcast. You need to be a practitioner to get Tro Plus Blue. Sign up at Transcriptions.com. Get Just Blue at Transcriptions.com as well, and save 10% on your order by using code POD10 at checkout. Now back to the show. This is as prevention. This is as prevention for COVID infection.
Right. Yeah. So, in my long COVID patients, I use that with some other nasal spray stuff we can get into, but to try to prevent, because I don't really, every time they get sick again, it's just like, oh my God, it's
everything
like they just slip really, but like just that spike protein and the virus just like destroys them again. So I want to just try to keep them healthy. But these are things that we should be talking about anyway for the general population moving forward. Like we really have to get prophylactics in place, building immune resilience and all that stuff is so important, right? So
yeah.
So I use those things. So those ivermectin. If they have like pulmonary, because still people are getting like lower respiratory infections. Doxy has great activity against the virus too. So I really like Doxy. I'll use Doxy, Zithromax also, Zithromax, Doxy. So I'll use those things as well if I have to. And of course, I'm using high dose D, high dose zinc, high dose C in addition. And I'll use liposomal glutathione as well, because we know from studies too that the virus depletes us like at an exponential rate of glutathione, especially most viruses do, but COVID really does. And that was even a study put out by the it was the NIH or the CDC back in like 2022.
So even more dramatically than most viruses, it just drops your glutathione level.
Yeah. So I'll pounce people with glutathione. Like I use the ReadySorb, and I'll put them on like 2 teaspoons, like 4 times a day,
Wow. That's, that's what I was going to ask you, because I knew we talked about the drugs. I was going to ask you about the supplements too. So.
Yeah. So I'm on like 10,000 of D a day, like, 4 grams at least of like vitamin C. I don't want to like make people get diarrhea, but whatever. I have them on like 60 to 100 of zinc. In the Medicinals 9, it has like the really high dose quercetin, piperine, the deglycerinized, the glycyrrhizin, but the glycyrrhizin that's in it is at the dose where it can't do anything to your blood pressure. It's at that like sort of lower threshold dose. It has bakelin, it has EGCG, it has rutin. This is really important too. The rutin is so important in combination with the quercetin, because people don't understand too, like quercetin, once it's in the gut, it's broken down to like 60 different metabolites, and it's not very effective. The rutin basically preserves it so that like 50% of the quercetin in its form that we need is getting absorbed.
So they have to be used together then. You have to use them in combination?
Yeah. So anyway, So that's what I do in acute. Yeah. And it works pretty well. It works out pretty well for most people. They do well. I will say I've never had an acute COVID patient of mine. I really can say this, go on to long COVID. I haven't had anyone go on to long COVID or long COVID in the traditional sense that we think. Right.
Yeah. And that's where I want to talk about now. So, we've talked about a lot of different things. And like, I could have dug into so many different things you've already mentioned, but I'm trying to keep it streamlined for people.
I'm sorry.
No, this is great. This is fantastic. So when you're talking about long COVID, okay, first of all, do we have we don't have we have a diagnostic criteria?
I'm so excited to talk to you about this. Can we talk about this? Okay.
Go ahead, please. Yes. Just talk away.
So this is my thing about long COVID. Okay. This is my thing. And people can think I'm crazy, whatever, but this is just how I feel about it. I'm just like, what is someone's long COVID, right? At this point, what is it? Because yes, everyone's like, oh, it's this constellation of signs and symptoms of these 200 plus things that can happen to you and blah, 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 right? But Scott, I mean, think about it. And we have these postmortem studies now to prove what the spike protein does. Like, what is someone's long COVID or what is someone's post-COVID condition? Right? Or post-spike condition? Is it the 35-year-old that dropped dead of a heart attack that was in the best shape of his life, that was like an elite athlete, and all of a sudden, or is it the 39-year-old the 21-year-old that showed up at the ER, like riddled with clots all over his body, who's also like in the best shape of his life? Is it the person that, basically developed this horrible, autoimmune disease that we can't even identify? Is it the person that, I don't know, that developed rapidly progressive neurodegenerative disease? I mean, I have 3 ALS patients or ALS-like patients in my office this past month. I mean, this is like a tsunami of disease and chronic conditions that we've never seen before. So I think it has to start becoming part of everyone's differential. I know I'm not trying to say it's the reason for everything. I feel like
syphilis.
What I'm trying to say,
it's like everything could be syphilis. Everything.
Right, the great masquerader. I feel like what it is we live in this toxic soup, and so many of us were living right here, and this pushed you over the threshold when you, when you got it, right, or when you got vaccinated, or when you got the virus, or something like that. And I think it's why we're seeing a lot of bizarre presentations that don't even make sense, right? And there's so many neurodegenerative diseases now that we can't even completely qualify. It doesn't really fit into that natural niche of oh, this is a straight up Parkinson's patient, or this is an ALS patient. It's these people with these motor neuron diseases or neurodegenerative diseases. It's almost like a potpourri, right?
Yeah.
Because we know that the spike protein causes the formation of all these different neurotoxic fibrils too, right? And it's throwing off alpha-synuclein. It's throwing off p-tau, alpha-synuclein. It's throwing off beta amyloid. And even we know, I know it's horrible to say, but in vitro, it's prinergic too, So this is a big problem.
Really?
A very, very big problem.
I didn't know it was prinergic too.
Okay, so I'll refer everybody.
Okay.
There's 2 very famous researchers, Per Hammarström and Sophie Nystrom. They're out of Sweden at a pretty big academic institution there. And they discovered what's called the Hammarström fibers, right? And so what they showed was, so when you get COVID, neutrophil elastase is activated, right? It's it's secreted by the neutrophils, and it's mobilized in many places, the brain, all over the body, okay? And once neutrophil elastase, which is an endogenous enzyme, right? If it comes into contact with the spike protein, right, it can expose certain epitopes because it starts breaking down the spike protein, right? And there's certain epitopes that Nystrom and Hammarström found, 7 in particular, that are neurotoxic. And in vitro, on contact with neutrophil elastase and the spike protein, you can see the formation of these fibrils on contact.
That's crazy.
One of them, the 525 peptide, they identified 7 different ones, is prinergic.
Wow. So you've scared everybody.
Sorry.
You scared me a little bit. That's okay. That's just good. So now that we know that it's doing all of these things to all these places and learning more all the time, what is your framework of working with the patient that you are very convinced has, symptomatology that could be related to long COVID? I mean, I know a lot of this is probably going to be related to, how do you, mobilize this spike protein? How do you bind it? How do you move it? Like tell me a little bit about your framework there and how you do it, how you think about it.
So most of my patients, I'll get the microclotting on them because I would say like 90% of them have that. And and that also gives like validation, because then that you're having this protein misfolding right off the bat. You're having probably a lot of endotheliitis. Oh, the other thing too, what's happening, which people should think about too, is the glycocalyx is being completely destroyed.
Right.
Like completely destroyed. And when the glycocalyx is destroyed, you just have this it's set up so perfectly for spike to just start flying into the endothelium and just causing this massive amount of endotheliitis, right? And then we know that then activates the platelets, and then that activates all these different clotting cascades and so on and so forth. And then all this, it's like just a vicious cycle of awfulness. So what we do is we want to do several things. We want to deal with persistent virus. We want to deal with spike. This is a very important concept to understand, and we have proof of concept with this too in the research. So we know that spike doesn't want to be in the blood. It's literally really sitting in the tissues, to be honest with you. It's like in the epithelium, it's in the tissue, all right? And when you give the senolytics, if you drew blood on somebody, like on most people, and you did a blood spot on them and then sent it off for analysis, because there are labs that can, my research is showing this, I'm going to be able to present this in a few months, whatever.
Okay.
But it will show this, that you won't see a lot. You won't pick a lot up in the blood, or even in the PBMCs, in the peripheral blood mononuclear cells, right? If you dose them with senolytics and then take the blood 2 hours later, it almost looks like a completely different patient.
Wow.
You'll mobilize spike in a lot of these patients, at exponential rates, and the PBMNs are then riddled with spike because they phagocytose it. And then you're like, oh, well, that's messed up, because now you infected all of these PBMNs with it, right? But the problem is those will regenerate, right? And you just want to take them out and get spike out, bind it, bust them up, get spike out intact, right? Because now I just taught you don't want to break the spike up because of these epitopes that could be possibly making things worse for a lot of people.
Right. Okay.
And I will tell you, I'm not going to name names because I don't want to make a big thing, but I was using some specific systemic enzymes, up front in the initial iterations of our protocol. We had them in the A beta 4240 in over 50% of the patients got worse. And then we got nervous that we were potentiating this beta amyloid formation from breaking spike apart. So you want to keep spike intact, bind it, but at the same time, remember I told you spike is a magnet for all these different host cell receptors. Yeah. So you have to have things on board that are blocking the receptor binding domain, right?
So they're out competing it, or they're competing for the same receptor binding domain, or how do you do it?
So so those polyphenol compounds, I'll share with you, we could put up a lot of the pathways, whatever, but a lot of those different polyphenol compounds will do this. They'll block the furin cleavage site. They'll block the RBD, because you don't want to then have the spike, if it's not all bound up, if there's any free, you don't want it then to go into a different cell and start causing the same issues, right? And make that cell a senescent cell. So it's very complicated.
Yeah.
It's
so you're
really hard.
Yeah. You're preventing it from binding to the tissue, or trying to prevent it, right? And that's with some of these polyphenols. And then you're trying to take it out whole and bind it. So what are you using for binding?
The senolytics. Okay. So they developed this product called senescence, which are a bunch of these different fisetin and very high dose resveratrol. And there's a few other things in there which acts as a senolytics. But remember, in the medicinals, there's also 4 different senolytics in there too. But you're only dosing the senolytics once a week. You're not, because you don't want to do too much of that, because then you could it could be bad, right? You have to be very careful. And then the binders, you're putting tons of binders on board, right?
What kind of binders?
Now, so the binders are fucoidon. Okay. Fucoidon is a Japanese seaweed. Okay. It has a very high affinity for spike protein. Heparin is one of the best binders to spike, and it has greater affinity than even heparin does.
Okay.
And then humic acid, there's a specific type of humic acid that's a very good binder that they sourced in Europe too. That's super helpful, because the problem with the humic acid in the ones that we were sourcing in the US, they're contaminated with fulvic acid, and you can't have the fulvic acid. It won't work. It doesn't bind the same way. And then there's some other binders. And then I started to use Pentacin, because Pentacin actually is a polysaccharide also, just like fucoidone, and it is very strong affinity to the spike, and it also acts as a weak anticoagulant. So I'll use that for 2 weeks up front at like a little bit of a higher dose, because I want to just like really bind up that spike. And I like to use it because I think it helps with the microclotting a little bit and like breaking that up. And the fucoidone, by the way, is amazing at restoring the glycocalyx. Like there's tons of studies to support that it helps with restoration of the glycocalyx layer. So, and I use like Endocalyx Pro and some of those other, like I use those products too. I would love to study that. I would love to do befores and afters with the glycocalyx check to see how we're restoring the glycocalyx after we move this out, because I think that we really are, especially given like a lot of the biomarkers that we're following, seeing the patients get better with that. But yeah, so we're doing the combination of those things, like putting on the omega-3/9, like I said as well. And then I'm just like adding things in as we go to rebuild, to restore health and balance of the gut microbiome. Because like I said, it's completely destroyed. So we're using like lorazepatide Pentacin. I'm using KP BPC 157. I'm using high dose zinc CD, because the combination of them, those on their own, what they do, and they also help with the phyto. I use serum bovine immunoglobulins, like a little bit more down the road. What else do I use? I don't know. I wish I had my protocol right in front of me, but I can share it for you.
Yeah, that'd be great.
So we're using all these different, so it's sort of like a layered process, like but that's just like foundational, right? Because now you're trying to mobilize and do this foundationally for everyone, and at least start getting it out of them, but then there's so much other work that has to be done, especially for so many of these moderate to severe patients that are so sick that haven't gotten to us for like 3+ years, right? So now they just have all this downstream inflammation and all these end organ and all these, and more like pathological things as a result. And I think at the end stage, we believe in our group, the end stage disease is really this autoimmune disease, where these people, and it's not a typical autoimmune disease, I'm saying, from all these autoantibodies and molecular mimicry that was created by the spike protein, right? And has done all this end organ damage, right? And I'm not even certain, I don't know, not to say, I mean, we're trying to test this too. Do those people still have spike even? Or is this just like, the aftermath?
Right.
And
it's
now
just a downward spiral.
And now you have to deal with that. And remember, it's like everything. It's like cardiovascular, neurovascular, thrombotic. It's cancer. I mean, God, the immunosenescence that is occurring, right? What it does to interferon, what it does, like that, we know the spike protein completely just regulates the T cells, the B cells, the natural killer cells, like all these different things. So like, that's why we're also so immune deficient. Like you see people now can't get over their colds like they used to. And now we have this whole epidemic, I'm sure you're following, a mycoplasma, right? I talked about at the conference, like 40-year-olds getting RSV, like ginormous, like parts of, my town, like so many people have it. Like I never saw that, so we're sort of like an immune deficient population because of this, know?
So this is a controversial question, but when it comes to long COVID in the respect of vaccine induced maybe versus wild type, have you seen any, I think maybe it's hard to even know at this point, because like there were so many people that have gotten the vaccine and also had wild type, and then vice versa. But do you have a sense of, at least from my perspective, like when I've used hyperbaric therapy in patients that have either been vaccine induced supposedly versus wild type, it always seems to be harder to treat the ones with vaccine induced. But what are you seeing in your clinic? Is there a difference?
It's funny. I find that that's true, but I also have a bunch of patients that got COVID early on and never even got vaccinated, and they are just as sick as the vaccine induced. It's really interesting. And by the way, I didn't mean to fail to mention like all the beautiful modalities that you'd like. HBOT is unbelievable, using all these other things, red light therapy, ozone, like all these other amazing
methylene
modalities.
Blue as well.
Like when
Sure.
you're oh my God, I'm using methylene blue. I bother you all the time about it. Yes. Like, and that's what I meant to say. Like after I do that part, I start really honing in. Oh, and I use the 1-MNA thanks to, Elizabeth up front. I use that up front in everybody. I meant to say that. Yeah. And then I really start working on the mitochondria, pretty within a few weeks or whatever. Like I'll see how the patient's doing, but I'm using like SS31 and humanin, and I'm using the methylene blue, and I'm using dihexa, a lot of these different peptides. And
you're tailoring it to the person.
You're tailoring, then that's where the precision comes in.
Right, exactly. You have like a general protocol for most people because you understand that you have to deal with the virus, you have to deal with the spike protein, and there's all these ways to do that. But then you have to say, like, where is their end organ damage, or where are they most symptomatic, right? And then that's when you're going to be tailoring their protocol.
Yeah.
But in essence, what you're seeing like sort of the downstream process of people having, continued spike protein replication, or if it's the virus itself causing all these things that you're seeing, like autoimmune like symptoms or issues, cancer, neurodegenerative disease that looks kind of weird. And I mean, I've seen this also in clinical practice too. I don't see as many people as you do, but it's been crazy, right? And my father's a chiropractor in New York. I think I mentioned, and he sees so many people, and then has so much more cancer in younger people, like these viral infections that are happening. It's kind of across the board. So I think what you said is really helpful, which is like, we're seeing, like, we have an immune deficient population now on some level, right? Because of these exposures that we've seen. So
I think Scott, you want to know what I think? I think we're going to have to move our screenings up. I think we're going to have to move the screenings back.
Wow.
We're going to
want earlier,
see
younger.
10 years. I'm sorry. Yeah. Move them. Yeah.
And
I really do, because I think it is a true age accelerant, and it's aging us so much quicker than we would have. So that's why we're developing all these things earlier. Like you're going to see neurodegenerative diseases in much younger patients, these cancers in much younger patients. Like we're already seeing it. I mean, it's, and then in the more moderate to severe patients that, sometimes the protocol, like it starts to move the needle, but not as much. Like you can use all these other amazing treatments, like the EBU works amazing. Oh my God, it's unbelievable. We're testing that right now to see how it's removing spike protein and the toxic like peptides, removal of that, because even though, again, you're going after the root, like getting rid of those which are, the circulating peptides could be helpful in just like relieving symptomatology.
Sure.
And cerebral lysine. Oh my God, I have such amazing results with the cerebral lysine. I can't even tell you. Like
this is for people with more neurodegenerative kinds of people.
Or even just the patients that have their head just feels like they just feel like they're under like water, and have all this pressure. And Suzanne Gaza taught me to use Nurtec like years ago. So I use the Nurtec, but I found now that like the Nurtec does work better once the patient's like a little better. I didn't have such a good response, but now I'm finding that once you get the patient like sort of over the hump, they're responding better to it. But there's all these different modalities that we can talk about, and all these different peptides repurposed. Oh, Amlexinox, thanks again. Like I was using it a little bit before I saw Betsy speak at the SSRP. And then I really started using it because she built like confidence in me. Yeah,
sure.
Dr. Yeah. And then I was like, wow, and then because I was pumping people full, because that's such a big deal too. I know I'm all over the place with the mast cell activation is so big, but if you can quell that and just like quiet it down a little bit and just get the person to feel better a little bit better, they'll get better faster. Right. And so using those mast cell stabilizers and histamine blockers, it just like sort of quiets things down. So they're not so revved up,
totally.
And it's helpful for a lot of people.
Yeah. So what I think would be helpful as we're talking is like, you've thrown like a lot out there as far as like what's
sorry.
No. What I mean is like, don't apologize. This is amazing, right? Like what I think is helpful from like a framework perspective is that you're not saying that you're using every one of these things with every single patient. The idea is that you have like a foundational number of things that you ask everybody to take if possible. And then you are directing some of these additional therapies depending on what their symptoms are. Like you talked about cerebrolysine specifically for these brain related symptoms, right? For example.
Methylene blue. The methylene blue works great for the chronic fatigue, PEM, the brain fog. Like I love it. It's great. Like a lot of these things that we're talking about.
Yeah, no, and I think that as people are thinking about this in their own practices, like, I know you've published a lot of this already and you're going to be publishing more. And I know there's very few people like you that are doing this. When you think about not only the, sort of the chronic treatment and like long COVID and the aspect, but like you talked a little bit about this earlier, which was, prophylaxis. Like you're basically telling me and us that we're all getting infected all the time, right? We're all getting, because it's out there, it's in the community. Our little cold congestions, whatever some of these are going to be COVID themselves, right? So is your a feeling that all of us should be on some sort of prophylaxis here all the time?
I do. And I think as a consortium, especially in our longevity group, and I want to really work together as a collective, I'd like to come up with better strategies. Like I think, I really believe the ivermectin's helpful. There's this nasal spray that also my group developed that has like a lot of these compounds that will block the binding receptor in the going nasally is great because that's where you're breathing it in, and so you can block that barrier from the virus attaching. And it works for other RNA viruses and for flu and things like that too. So or just any other product like that, right? Like even Pentacid could be great intranasally as well. And just coming up with strategies so that when you're in big crowds and when you're going places that you're protecting yourself and maybe doing like one or two sprays, like I'll be doing mine like when I'm in Las Vegas next week, like I just, but even on a daily basis, I take it and I will admit I take ivermectin prophylactically as well, based on that study.
Like
I've been
once
doing
a
it
week
for years.
Or twice a week, that kind of thing?
I do 4 pills a month. So I dose myself at 0.2 mg per kg. I do Monday, Tuesday, and then I skip a week and then Monday, Tuesday, and that's what I do.
And you do your nasal spray on a regular basis too?
I do.
Yeah. What's in the nasal spray that you guys have developed? I know you said there's
developed. It's not available in the US yet, but it will be soon. But I'm saying, we can work on other strategies in the meanwhile. Like I said, like Pentacid could be great, because it's such a strong binder to spike, right? It really is. And so we can come up with other, I know obviously povidone iodine is another good strategy. The Cofix RX, that's another product that I used for a while too. But the problem with iodine, again, like the patients were using it too much, it can screw up your thyroid. Like so that gives me, some problems. And I feel like you're always exposed so much now. And like people are so not living in a bubble that like, I feel like you have to come up with things that are like safer and that aren't going to really do things that you worry so much about, that are more natural, that like you can take on a daily basis without having to worry about anything.
One thing that worries me, and I know this probably worried you, Robin, and in the beginning of the pandemic, like I was in California at the time, and so my kids were home, right? And I was talking to our friends with kids be like, oh, this has been like the greatest year. I mean, COVID sucks, but none of my kids have gotten sick. This is so great. I'm like, no, like your kids need to get sick. This is what's really important for their immune system. And like they really need to get sick. But now you're basically telling us that we don't want to, ever get sick because we want to have Pentacid and we want to have is it different for kids? Is it different for adults? I mean, what do you think here? Because I'm concerned, that
I think I agree with you. We need to get sick. Like, I just think it's like more preventing this,
this particular thing, this particular
or just like squashing the viral load. Like you want to just like, and everyone thinks it's so annoying to test, but like, and the other thing is the tests are so inaccurate now too. But if you know you have it and you test, like you should treat like right away.
Got it. And it's not about waiting anymore.
They have studies coming out too. I will say this, like, you got to wait for it to come. But she's showing too that once you get the virus a few times and you treat this way, right, and you give the antibiotics, that you're actually much less prone to then contracting the virus again.
Interesting. So
these are things we need to follow, because then these are strategies we could implement in a lot of people up front. And then see how this plays out, right? Because then you're right. Then you don't have to like worry so much, and you can get your other viruses and whatever. And
right. I know. I mean, it's one of these weird things. Like you don't want people to live in bubbles, right?
No,
Like,
and I'm not suggesting we do.
Yeah.
I'm not, I'm just thinking, God, like, we got to get either some, treatment strategies in place, or people should have something in their house, like ready to go. Right. Like,
right. Their go bag.
Because even if you feel like, because here's the thing, it's a virus, right? Either way, however you slice it. And most things we get are viruses. So even if you have something in the house, when you feel like you're coming down with something, and you just start it, and then you could like beat it fast, like, how good is that? No matter whether it was COVID or not, you still got it. Your immune system still got pumped and primed, but you'll beat it faster.
Totally. Yeah. And I think that's like having your go bag or having like your emergency supply.
Yes.
Yeah. Having like your emergency stuff like ready for you, for sure.
Yes.
Yeah.
That's what I think. Because
whenever have some basic prophylaxis, I mean, most of us.
Yeah. No, I'm saying that's what I do. Like, when I start feeling like I could be, or maybe this is like, I just like slam myself, and then like I'm better pretty fast, so whatever I did, I squashed it. That's what I want to do.
Yeah.
With this too.
Well, I have like so many more questions, but I think that, we've gone through like a tour de force of your brain, Robin, which I love. I know there's so many other pieces of this, but I think you gave us a really great, overview of, your history, like how COVID has changed over the years, how infective and crazy this virus is, and how many systems it affects, and what we can do like acutely, what we can do chronically, at least in basic form. I probably will ask you to send me over like your protocol or something that you feel comfortable sharing, just so people can get a framework. But, the last question I ask everybody at the end of the podcast, which, it could be, this could be about COVID. It could be about anything you want. Is, what are the 3 ways that you would recommend all of us avoid COVID? I'm just kidding. Or 3 ways that you think that, we all can live smarter, not harder in any part of your life. I know you're a very busy lady, Robbie. You have a huge clinic. It's a telemedicine practice. You're seeing people all over the country. And I'm going to ask you about all that in a minute. But like, if you have lots of patients that are coming in all the time, you have your own personal life. Like, what do you say, like the 3 things that anybody can do to live, smarter, not harder in your respect?
Okay. Ready?
Yeah, I'm ready.
So you have to, and this is something like I'm really not good at, but you have to practice self-care and putting yourself first a little bit. That's my first, and all the things that come with that, like getting to the gym and actually moving, right? And trying to put the good food in your body, and not like eating like candy and chocolate all day because you're stressed out, and, handling your stress the right way, and, sleeping, obviously, which is your foundational, pillar. That's one, which I have to really practice, like, because I am not good, because I put everyone else before me.
I'm with you.
And everything else before me. And because that's how we are. That's why we're empaths and we're doctors, right? So that's it. Then the second thing that I've learned too, especially after the pandemic and going through all this, is don't sweat the small stuff. Like, I used to just get so upset about the little things, and like, you just have to really like look at the big picture, right? And I try to like tell my kids that now, right? Because it's just not worth it in the end. And the third thing is be present and live in the moment, because I really didn't do that. And that's so amazing for your health. Like, just to be there and live in the moment and be surrounded by your loved ones and your children and your family and your friends, and be surrounded by community is so powerful for your health, right? And like, I was like always like half in, half out, because I'm thinking about 20 other things and whatever. So I really tried to like, really be mindful and like really be present, like whenever I'm doing anything now, whether it has to do. Yeah. So those are my 3 things.
I love it. And being present in the moment is not what doctors are trained to do, which is hard, right? We're always thinking about what could happen in the future. And then you have children, and then you're always thinking about what can happen to them. But even before that, I mean, it's natural in the human form, the avatar, the meat suit that we wear, that we're always trying to plan for the future so we don't die, or that we can procreate or whatever.
Correct.
So I think those are beautiful. Thank you so much, Robin, for being here. I want to ask, where can people find out more about you, and then about the clinic that you run, because it's this fantastic, cool place that you've created?
So our website is trainhealth.org. And we are in Fairfield County, Connecticut. So like right outside New York City. And you can also, I'm on Instagram at dr.robinrose. That's my handle at that. I don't know. Where else can you find?
You do telemedicine as well, right? So you're not just seeing patients.
I have multiple licenses across the country. So I can do telehealth in like multiple different states.
Right.
If it is a state that I don't have it in, people can establish care. They fly in and establish care. And we built out like a beautiful IV suite with protocols that I developed too around this. And like, I will come back to you, Scott, within the next few months, because we are going to have amazing data showing what we're doing with spike, what we're doing with these toxic like peptides, what actual cells are being infected, and how we can even personalize treatment more to people when we have this information, because now we can quantify it in the research realm. Like eventually it would be amazing to commercialize this, right? For people to know.
Well, I look forward to having you back on, Robin. I know that there's much more to get into. I look forward to seeing you in Las Vegas next week.
I know, I can't wait.
It's going to be fun. Well, you can show me your Pentacin spray, and I can borrow some. But you are taking new patients across the country, right?
Oh, yeah. At this point. Oh my God. Yeah. Mm-hmm.
Yeah. Great. And I just want to thank you for being here. Everybody, thank you so much for listening this time on the Smarter Not Harder podcast, and we'll see you soon. Thanks, Robin.
Thanks, Scott.
Thanks so much for tuning in to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. I had an amazing time speaking to Dr. Robin Rose today. She's just a wealth of information, one of the few people out there that's taking the research and doing this in clinical practice, doing her own clinical research at her facility at Terrain Health in Connecticut. So please check out her work. There's going to be more coming from Robin. This is just the beginning. This is not very common for her to do podcasts. I really was excited to have her. You're going to see her on more because she's on the forefront of all of this. So if you like this podcast, don't forget to like and subscribe below, share with your friends and family, and we'll see you the next time.